Thanks to all of you for joining me during your busy days. I hope you find this useful. So we're going to be talking all about that gut-hair connection, really getting down to those root causes of hair loss and fixing them that way instead of just suppression. I'm Dr. Julie Greenberg, a licensed naturopathic doctor and registered herbalist. I specialize only seeing dermatological patients through my clinic, the Center for Integrative and Naturopathic Dermatology, and I have a site, Root Cause Dermatology, with functional dermatology education that I'll talk a little bit about, and I hold degrees from Bastyr, Stanford, and Northwestern universities. All right, so let's jump into it. Let's talk about some hair basics. So, some facts about hair. Hair does not serve any crucial physiological function in modern humans. So you can live a very healthy life without having hair, but it can have a huge impact on self-esteem. And it's not just people internalizing the hair loss. There's a lot of societal bias, and we'll take a look at that. People have an average of about 5 million hairs on their body, and the hair on your head grows on average 6 inches a year. We normally shed anywhere from 25 to 100 hairs a day from our head. That is totally normal to see hair coming out in the shower, on your clothes, or in a hairbrush. And hair loss will affect almost half of people in their lifetime. So this is a big, big problem. And if you're a practitioner, you're going to see it. And I just like to be clear that the term alopecia, the definition is the partial or complete absence of hair from areas of the body where it normally grows. So there's lots of different types of alopecia. We'll talk about this, but just alopecia in and of itself is not a diagnosis. We need to know what type of alopecia it is. And we see this beautiful peacock here with his gorgeous feathers. And I think of our hair and our head kind of like this. You know, the feathers, again, don't serve a crucial physiological function for the peacock, but it's a signal to the peahens of how healthy this male is and why they should breed with him, and it looks quite spectacular. And the hair on our head is the same thing. It's a signal to others of our health, and it's become a standard of beauty. And so it's really our crowning glory, and it's really important to people what their hair looks like and that they have hair. So let's look at the stigma towards people with alopecia. So there was a study done, and there was about 2,000 healthy people, and they showed them images of 6 different people, different genders and different ethnicities, with varying degrees of hair loss. So picture A, we see full hair. Picture B, there's just hair loss on the scalp. And picture C would be total hair loss, so no eyebrows, no eyelashes, no hair on the head. And they asked people kind of their feelings about it. And for C, the most severe hair loss, the ratings that people gave, about almost a third of them said, well, I think that person is sick. And for women, they normally think it's cancer treatment. Unattractive, people said 27%. Then we even got things like contagious, unintelligent, dirty. Now, of course, whether or not you have hair has nothing to do with your intelligence or your cleanliness, but unfortunately, this is the societal implication of hair loss. So it's not just people with hair loss internalizing that others are judging them, it happens. And there's even workplace bias. 17% said they wouldn't feel comfortable having physical contact with somebody with hair loss in the workplace. And 6.2% said they wouldn't feel comfortable hiring them. So people can even be losing jobs with hair loss. So things to keep in mind when treating hair loss as a doctor or practitioner. It is a very difficult journey, both for patients and doctors. Of course, more so for the patient because they're experiencing it, but we all know as doctors and practitioners, when our patient is having a tough time, we're having a tough time as well. And why is it so hard to treat hair loss? Well, there's a lag in what you're seeing, and we're gonna look at why that is, but generally what you're seeing now on hair loss really happened a couple months ago. And so even with pharmaceuticals, it doesn't matter what you're treating hair loss with, you have to wait sometimes 6 to 12 months to know if something is even working. So that's frustrating. It takes a long time to treat hair loss because of the slow growth of hair. It's not like a rash or something where you put something on and it's very obvious very quickly whether or not something is working. We got to be patient and just let that hair go through its cycle. And it's really an emotionally taxing disease. As we talked about, there's societal bias, and it's very hard for individuals to not have their hair. So let's look at the hair growth cycle. And we're going to talk about anagen, catagen, and telogen, and why it takes so long and why there's a lag. So anagen is the initial growth phase of hair. And we're talking about hairs on the head for this example. So hair on the head can spend anywhere from 2 to 6 years in anagen or the growth phase. That just depends on your genetics. And 90% of the hairs on somebody's head are supposed to be in anagen in this growth phase. What we notice here is that this yellow going into the hair follicle is representative of a blood supply. And in the growth phase, we have a very robust blood supply to the hair. We'll talk about it, but hair is a nutrient hog. It needs a lot of blood supply. So this is growth. The next phase that hair will enter is called catagen. And this is a transitional phase. Lasts from about 1 to 2 weeks. About 3% of the hairs on the head should be in catagen. And what we notice here is that that formerly very robust blood supply is starting to get thinned and choked off. So the transition is that it's being cut off from the blood supply, and that will happen over the 1 to 2 weeks. Then we enter telogen. Telogen is the resting phase. And what we see is there is no blood supply. There's no saving this hair. This hair is dead and gone. It's just sitting in the hair follicle waiting to come out. And it can sit like that for 5 to 6 weeks. 6 to 8% of the hairs on the head are in telogen. What often happens is that that follicle will enter early anagen again, and we see a new hair coming up through the hair shaft into the follicle, and it will bump out the dead hair that's just been sitting in the shaft for 5 to 6 weeks. But these are hairs that, like, again, when you run your hands through your hair and the brush, you don't feel them coming out because they've been dead and sitting there. That's very different. If you pluck out a live hair, it's like, ouch, you know, you feel it and then you see a little bulb on the end. So that's a hair in anagen. But all of the ones that you see coming out, it's not painful, you don't feel it because they've been sitting there. And so this whole process, you know, can take a long time before we even see a new hair. And that's why it can take many months before we even know if something is working. Okay, the structure of hair. So as we've talked about, the hair really has to have a robust blood supply here through the papilla. It's vital for hair growth as well as hair health. It really requires a lot of nutrients, and without the blood supply, it's not going to get it. And all of the graphics show this, you know, one blood supply going in, but what's the reality is that the hair follicle is being bathed in this gorgeous capillary plexus around the hair follicle. And I just thought this was such a great image that I wanted to share it with you. So just being bathed in blood and nutrients so that the hair can grow, just like the peacock feathers. So we're saying it needs a lot of nutrients. What are the nutrients for optimal hair growth? Well, hair follicles are some of the most metabolically active sites in the body. They're going to take up whatever's in the blood. That is why when many people get chemotherapy, certain kinds of chemotherapy, the first thing that will happen is their hair will fall out because it's so active. It's pulling up everything from the blood. Now, nutritional deficiency, we know, absolutely can affect hair structure. So we need appropriate amounts of protein, iron, biotin, vitamins A, C, D, E, zinc, silicon, selenium, all the nutrients to support healthy hair growth. But what I do not do with my hair loss patients is just throw a high dose, you know, hair growth supplements at them. Why don't I do that? Because there's really limited information on it helping. In the absence of deficiency, throwing high dose supplements at somebody is not going to fix their hair growth. And worst case scenario, you can get possible toxicity from over supplementation of certain nutrients like iron, vitamin A, vitamin E, zinc, or selenium, right? We can get a buildup. So the starting point is not a high dose multivitamin. Starting point is figuring out what are, you know, what's going on, what are the causes of hair loss. That's going to include a really good clinical history. You're going to look for the risk factors for deficiency of those nutrients. So this is a chart that shows us a medical or dietary risk factor. So obviously women who have a lot of menstruation, a lot of bleeding during their period, they're going to maybe be iron deficient. You'd want to check in for that. There's malabsorption disorders, things like pregnancy, alcoholism, but also drug use. So H2 blockers use, anti-epileptics, antihypertensives, prolonged antibiotic use. These can all lead to nutrient deficiencies. Certain areas of the world, there'll be deficiencies in the soil. Vegans and vegetarians, right? You want to watch out for those things like iron and zinc, maybe vitamin B12. So get a good clinical history, determine whether there's possibly an obvious nutrient deficiency, and you can do nutrient testing as well on your patients to see if they are deficient. There's also standard blood work I like to run in my hair loss patients when I'm doing an assessment. I want to get a CBC, an iron panel, and a ferritin, ruling out anything like an iron deficiency anemia. A thyroid panel. Absolutely, the thyroid impacts hair growth and hair loss, so we want to make sure that's not the problem. Maybe a vitamin D, maybe zinc or other nutrients, depending on that clinical history if I'm worried about certain things. And I might check hormones as well, because the problem can be at the follicular level. The hair follicle doesn't just take up nutrients, it takes up hormones from the bloodstream. So it will take up androgens like DHT or dihydrotestosterone, which can drive hair loss as well. So these are kind of starting points for me to know, like, are these the kind of basic low-hanging fruit that's causing my patient's hair loss? Because these are, things that we can go after and fix. But a lot of times it's not. So when we look at the world of hair loss, dermatologists really kind of put it into three big buckets. There's non-scarring, scarring, and mixed. So let's look at them. The non-scarring bucket means that hair follicle is intact and regrowth is possible, although not guaranteed. So it's good to be in non-scarring. What are examples? Well, alopecia areata is one. We're going to really drill down. We're going to look at some case studies on approaching alopecia areata from a root cause and fixing it. There's two different case studies we'll see. So that's the autoimmune attack on the hair follicle. There's androgenic alopecia, which is kind of that hormonal hair loss. And telogen effluvium is a kind of sudden shock or trauma to the system. It can be anything from an illness, a death in the family, a surgery, just any big kind of life change can cause a sudden loss of hair. And all of these are non-scarring. The next bucket is scarring, also known as cicatricial alopecias. And in this, the hair follicle has been destroyed and hair loss is basically permanent. So the types of scarring hair losses are frontal fibrosing alopecia, lichen planopilaris, discoid lupus erythematosus, and central centrifugal cicatricial alopecia. And biopsy can usually determine whether it's a scarring or cicatricial. And then there's mixed alopecias. Mixed means that it starts off as non-scarring, but if it goes on too long, it can become scarring over time. And examples of mixed are traction alopecia. This occurs in people who are wearing hairstyles that are pulling on the hair follicle. So it could either be for a job like a ballerina, or it could just be the type of hairstyle that's pulling. And with enough time, that the traction on that hair follicle causes trauma, and then the hair follicle stops growing, and the hairline will keep moving back if the traction keeps happening, and it will be permanent if it goes on too long. And trichotillomania is hair pulling, so that's DSM-5 disease where people are pulling out their own hair, and again, if they continue to do that, it can become scarring. So in addition to all of the ones I just talked about, the diagnosis for hair loss is pretty vast. So here's a patient of mine, and if we were in a room, I'd ask, do you think this is just sebderm of the scalp, just really bad dandruff? Do you think it's scalp psoriasis? Do you think it's tinea capitis, a fungal infection? Or do you think it's iatrogenic caused by a medication? And the answer is, it is very bad dandruff. It's sebderm of the scalp. And this has been very severe. This patient has had it for a long time. We can see a lot of erythema and hair loss. So your differential diagnosis for hair loss is really vast when you're starting. You have to do all of this work out to figure out what kind of hair loss is this actually. Now, let's drill into a specific type. Let's go into alopecia areata. Which is, again, it starts off as non-scarring, and we can see can happen all over. It can happen in the beard, it can happen in the scalp, anywhere that there should be hair growth. So alopecia areata, this is the autoimmune attack on the hair follicle. We get areas of non-scarring hair loss that range from just a single oval or round patch to then multiple patches that can become confluent, can take over the whole head or the whole body. Relapses are common. Only a third of cases achieve long-lasting remission. I mean, this is because they are not getting to the root cause, but we are going to talk today about getting to the root cause. It's most common in children and then young adults. So 60% of people will have onset of AA under 20 years of age. And there is definitely a genetic pattern of inheritance. So check that family history to see if there's alopecia areata in the family. And just like all autoimmune conditions, it's associated with then developing additional AI conditions like a thyroid disease, RA, vitiligo, etc. There's different types of alopecia areata. So usually the first stage and the kind of most mild level is patchy alopecia, where we get one or more either round or oval coin-sized patches that develop often on the scalp, but again, anywhere that the body grows hair. So it could be the pubic area, it could be the legs or arms or the face. The next type is alopecia ophiosis, which is kind of a snaking band around the sides of the head that meet in the back. Ophis means snake in Greek. This is a less common one, but can happen. Alopecia sisypho is ophiosis backwards. So instead of loss from this area, it's loss across the top and middle part of the scalp. And then alopecia totalis is when these progress and then there's hair loss on the entire scalp, so completely bald. And alopecia universalis is the most severe, where there's hair loss across the entire body, including no eyebrows, no eyelashes, nothing on the arms or legs or pubic hair, just every hair follicle on the body is being attacked. And it can be mixed. So you'll see the patient examples got patchy and ophiosis. Patchy alopecia is easier to treat than the other variants. We want to catch things early before the disease state has progressed. It's a lot harder to treat totalis and universalis. The pathophysiology. So what is going on in the body that makes somebody attack and kill their own hair? Well, we don't really know, like almost all immune diseases, cause unknown, but we know that it's mainly a T-cell mediated disease, and we're going to look at those T cells. So Th1 producing interferon gamma and Th17 producing IL-23 and IL-7 are kind of the main components of most autoimmune attacks and the main component of alopecia areata, but we can find other T cells like Th2 and Th9 involved as well. The correlations that we have are to genetics, as we talked about, viral and bacterial infections, vaccinations, T-cell priming in gut mucosa or peripheral lymphoid tissue, and total lifetime and early childhood traumatic events, or ACEs. We're going to talk about the viral and bacterial infections, the vaccinations, and the T-cell priming in gut mucosa as these drivers. So I know this is a savvy crew, and you guys already know that what is happening in the gut is really training and modulating our immune system, right? There's a lot of crosstalk between what's going on in the gut and the microbes we have in the gut, and then whether our immune system is activated or calm, and that happens in a variety of different ways. But let's drill down to the T cells, because we know that fundamentally alopecia areata, and again, most autoimmune diseases, are T cell mediated disease. It's an attack of the T cell on the body. So let's take a step back and revisit the T cell if it's been a while since you've been in an immunology class. When we first create a T cell, it is called naive. And the reason it's naive is that it needs a signal from the body. What's going wrong? What do you want me to be? What am I supposed to go fight? And where it gets that signal is via these dendritic cells, which are information passing cells from our organ systems in the body that interface with outside world. Well, what are those? Our skin, of course, always interfacing with outside world. So you get a paper cut, bacteria goes in, it's going to activate a T cell and go develop one to fight that problem. Our respiratory tract. You breathe in COVID or the flu, same thing. The dendritic cell is going to pass that information and activate it on a different path. And our gut microbiome, of course, every time we eat or drink, that's outside world coming in. A lot of dendritic cells in our gut passing information to T cells. So once the T cell gets activated, it depends on what it needs to fight. So if we look here, Why would a T cell activate and become Th1 and then secrete interferon gamma and TNF alpha? Well, if there's intracellular bacteria, viruses, or protozoa, then this will activate down this pathway and we'll get Th1 cells. Th2 is an allergic pathway, so things like worms, fungus, and allergens. Well, we see this a lot in eczema. Th17 gets activated from extracellular bacteria and fungus at mucocutaneous sites. Well, what's one of our biggest mucocutaneous sites? Our gut. So if we have bacterial overgrowth or fungal overgrowth in the gut, we're activating the Th17 pathway. But other mucocutaneous sites is our throat, and we're going to look at a bacteria in the throat that can, we're going to look at some bacteria in this area that can activate this pathway. And then Th17 cells will produce IL-17, for example. The Treg cells are, of course, those calming cells indicating immune tolerance and immune regulation. These are going to be downregulated in any autoimmune disease, and we're going to see these guys upregulated. So a lot of Th17 and Th1 activation for alopecia areata and autoimmune diseases. Okay, so let's go look at intestinal hyperpermeability or leaky gut. We know that this is a healthy gut, right? What are we seeing? We are seeing strong mucosal barrier. We're seeing strong, tight junctions between the cells of the intestine. What does that mean? That nothing unwanted is getting into the bloodstream below the gut. So this is a calm immune system. We are digesting food and allowing nutrients in, but not bad guys. And the dendritic cells we can see are nice and calm. What contributes to a healthy gut? Well, there are keystone bacteria, and these keystone bacteria are measured in the GI map, so we're going to look at some results. But things like Akkermansia muciniphila, it's in the name, mucinophile. That means Akkermansia loves mucus, because Akkermansia lives in the mucosal surface of the gut, but eats away the old and stimulates production of new mucosal surfaces from the goblet cells. So we like Akkermansia. And Fecalibacterium prausnitzii is another keystone species that we can see on the GI map, and it produces butyrate that feeds these cells and enhances tight junctions. So we want the healthy gut bacteria. We need that in order to maintain a healthy gut and a calm immune system. With the leaky gut situation, we see immediately that we have a big disruption here in the mucosal surface. That mucosal barrier has been degraded. Now the cells of the intestines are open to the bacteria and contents in the lumen, and they become inflamed and die. And that leads to the leaky gut, meaning a pathway into the bloodstream for unwanted things, like LPS, that stands for lipopolysaccharides. These are endotoxins from gram-negative bacteria. Very inflammatory. We can see here a dendritic cell has grabbed onto the endotoxin, and that is going to trigger inflammation. Well, what does IL-6, TNF-alpha, and IL-1 beta drive? It drives production and activation of Th17 cells. So when we have bacterial and fungal elements and overgrowth in the gut, or driving a Th17 process. And it's not just things like alopecia areata, but psoriasis is a Th17 driven process as well. So we can see now how the gut directly relates to our immune system and these diseases, and why we have to test the gut and treat it in order to get to the root cause of these problems. So that gut-hair connection, right? We know 100% that gut dysbiosis drives systemic inflammation. And sometimes I think we forget that with derm diseases, and hair is included in dermatology, it's a chronic dermatological disease. It's chronic inflammation. We go back to the root cause to clean it up. And so we'll look at some cases. I test and treat the gut. So I run a GI map on every patient who comes through my clinic, every single one. Okay, so let's go back to what's going on with the attack. Let's look at a normal follicle and anagen, and now we know that anagen is in the growth phase. So here we've got the hair, it's connected to its blood supply, and there's always all of these immune cells floating around. We've got natural killer cells and T cells and mast cells, more T cells, right? But the follicle has something called immune privilege, where all of these cells are supposed to recognize, oh, that's self, that's us, that's a hair follicle. We leave that alone. We don't touch it. The follicle in alopecia areata is under attack. It's a collapse of the immune privilege. Now, there are factors that we know stimulate it. So we know things like trauma, infection, and stress trigger activation of cytokines, mast cells, T cells, natural killer cells. And we're going to see interferon gamma in a minute, but it drives the production of that interferon gamma, and then we get the collapse of immune privilege where it's starting to be attacked by the T cells and other cells as well. And then we get the hair loss. Okay, let's look at some correlations. So let's look at bacteria and immunizations. So bacterial pathogens and immunizations have been found to be potential risk factors for the development of alopecia areata. This study did throat test swabs of 65 men and women with alopecia areata and compared it to the throat swabs of 65 healthy controls. What they found was if you had a history of getting a vaccine or immunization within the past 6 months, your odds ratio of developing alopecia areata was 3.3. That's very significant. And the presence of bacterial pathogens in the oropharynx increased the odds ratio by 2.6. What lives in the oropharynx? Well, they found things like strep pyogenes, but they also found Klebsiella pneumonia, Pseudomonas, Streptococcus, E. coli. And what is the oropharynx? A mucocutaneous site. What does bacterial infection at mucocutaneous sites drive? Th17 pathway, right? So we can see why having a bacterial infection in the oropharynx would drive it. With vaccines, so vaccines, of course, have been transformative and have been life-saving, but they are asking the immune system to ramp up to fight the thing we've just injected with the vaccine. And we don't have control over the way the body responds to that signal to ramp up. So is it possible that the immune system, goes on to overdrive? It's possible, but I really do see in my clinical patient base that bacterial infections in the oropharynx in the mouth and history of vaccination, I see a lot of it in my alopecia areata patients. Now, interestingly, we saw that interferon gamma kind of can drive this process. Neutrophils produce interferon gamma early during pneumonia induced by strep pneumonia because it regulates bacterial clearance. So maybe the body's producing all this interferon gamma trying to clear the infection, but then, with too much overload in the system, it goes wrong. There was an interesting study done on mice. They were looking at intestinal dysbiosis plus biotin deficiency. Now I know biotin gets, a lot of play for hair loss, and it's like throw high dose biotin at your patient. But again, that's really not the path you want to take unless there's true biotin deficiency. So in this study, mice were treated with antibiotics treating gram-positive and gram-negative bacteria. And then they were also fed a diet, either a normal diet with appropriate amounts of biotin or a diet completely devoid of biotin. What they found was that there was no alopecia in mice groups that were either given just a biotin deficient diet. So even not getting biotin was not enough to drive alopecia areata. Or if they were just given antibiotics, they were still okay. But if they were on a biotin deprived diet plus on vancomycin, they developed a gut dysbiosis, and this led to severe alopecia areata in the mice. Okay, let's look quickly at what your patients might be on. So first-line therapy, especially with patchy alopecia, is to do corticosteroid injections into the scalp, the Kenalog. They have to have multiple injections every 4 to 6 weeks. It's pretty painful. You can use topical minoxidil in conjunction, but topical minoxidil alone is not effective at all for alopecia areata. And of course, what is this? This is immune suppression. We're just trying to suppress what's going on in the scalp and see if we can clear up the alopecia areata. For those who can't tolerate the injections because they are very painful, like kids or some adults, then they're going to use really strong topical steroids on the scalp. Then you start stepping up to kind of more severe topical immunotherapy, and then you're going to do systemic glucocorticoids like prednisone, again, trying to now suppress the entire immune system. And sometimes there will be regrowth, but then a lot of times once the suppression stops, then the hair loss goes back and continues again. Then you can do more extreme systemic immunotherapy, things like methotrexate, cyclosporine, azathioprine. Before, there really weren't good treatments, in terms good being that there wasn't good results. If you failed the steroid injections in the scalp, then doctors didn't really know what to do for you. Now there's these JAK-STAT inhibitors that are coming hard, especially for alopecia areata. They're kind of the new kids on the block, and they're being used extensively in alopecia areata. But the JAK-STAT pathway communicates information from chemical signals outside of the cell into the cell nucleus. It's regulating activation of genes through transcription. So this is a very wide-ranging signal. And while people are getting good results in terms of hair regrowth on JAK-STAT inhibitors, you have to stay on it because it's just suppressing the immune system or the benefits are lost. And this is such a wide pathway. I mean, gene transcription, just anything outside the cell coming in, that I fear that in 5, 10, 15, 20 years, we're going to see a lot of really bad side effects from these JAK-STAT inhibitors. And I don't know, I think they might even come off the market eventually. So again, suppressing the immune system even harder sometimes works, but you've got to keep suppressing the immune system. There's fecal microbial transplants, which are quite interesting. This is when a fecal preparation from a healthy donor is transplanted into the colon of a sick patient. We think it kind of repopulates the gut microbiome. It can only be used legally in the US for C. diff infections that have failed antibiotic treatment, and if you get special permission for research. So sadly, this is not something that we can just do for patients. But there are case studies showing that fecal microbial transplant can be effective in regrowing hair. What are we going after? The gut microbiome. So here is a case study. A 20-year-old patient started developing alopecia areata. A few months later, we can see it's pretty much spread across most of his scalp. And then he received fecal microbial transplant, and this is 1.5 years after fecal microbial transplant. So again, looking at that gut microbiome, FMT is not legal in the US. There are some beautiful herbs that we can use, non-pharmaceuticals. Scutellaria bicolensis has been found to lower Th17 cells and its related cytokines, and it increases those Treg or modulating cells. And you can use it orally and topically in capsules, tinctures, or glycerates. There's lots of studies, and don't be confused, it's Scutellaria bicolensis, not Scutellaria lateriflora. This is Chinese skullcap. It's used very extensively in traditional Chinese medicine, but it's also in the formulary of naturopathic medicine. And there's lots of studies, especially on bicolin, the constituent in bicolensis, showing us that it decreases the Th17 cells and helps to calm the immune system. All right, so let's get to the good stuff. Let's look at a case study and see a patient walks through your door with alopecia. Now you know you need to do a workup to figure out what kind of alopecia is it. But once you know that it's alopecia areata, what do you do to help stop this process and help regrowth hair? So let's look at John. He's going to be the first patient. These aren't the real names of either patients, by the way. So John is a 25-year-old male. He's developed alopecia areata about 4 years ago. It started in college when he was drinking a lot. Alcohol is a toxin. It also degrades the mucosal barrier and leads to leaky gut. The first spot he got was on his lower right hairline. He just thought he was stressed out, no big deal. But then he got a second one, so he went to a dermatologist and was diagnosed with alopecia areata. He started the cortisone steroid shots about 7 months later, and he said it made it worse. I don't think the steroid shots made it worse. I just think his disease was progressing quickly at that state, and it certainly didn't help. So he saw a functional medicine doctor. He tried a vegan diet. He tried low-dose naltrexone. Nothing was working, kept getting worse. So this functional medicine doctor referred him to me. We looked at the lab work. There was no significant findings on his lab work. He wasn't nutrient deficient. He wasn't iron deficient, nothing like that. Thyroid was good. So the next step, we've got to do a GI map stool test, and then I also do some other tests as well. So just to give you a kind of perspective, it's really spreading all over the place. And if this continues, this is going to go to totalis. He's going to lose all the hair on his head, and then eventually it can progress to universalis. So when it comes to autoimmune diseases, there's always kind of two buckets. There's always the gut dysbiosis. So I've always got to do the stool test and the gut testing and see exactly what's going on in the gut that needs fixing. But there's also usually this toxic piece that throws the body into overload. And I think that's where we start to see the autoimmune attack on self, right? Things have to really be going wrong where we start killing our own tissue, because the number one rule of being a living being is stay alive, don't kill self. And that is what's happening in autoimmune disease. So it's like peeling the onion. We have to peel all the layers, start with the gut microbiome, and then keep looking for the other pieces that might be a factor. So with John's GI map stool test, I saw that there was some H. pylori. So this is 260, a kind of low, moderate amount. But what was interesting about his normal gut flora was they were too low. So this is a picture of insufficiency dysbiosis, insufficient amounts of normal gut flora, which is an inflammatory state. This is not regulating the immune system. So we can see that his whole phyla of Bacteroidetes is too low, and he's missing that Akkermansia muciniphila. No Akkermansia muciniphila is often a proxy for a leaky gut. On this kind of unwanted opportunistic bacteria, we're seeing that there is some overgrowth here as well, some Staph aureus, some Streptococcus, some Enterococcus faecalis and faecium, and some Candida showed up on his stool test as well. We've got fungal overgrowth. He's also got protozoal overgrowth. And if we think about what we've looked at, right, the bacterial overgrowth, Th17, the fungal overgrowth, Th2. The protozoal overgrowth, Th1. Now we can start to see how all of these T cells are getting driven by what's going on in his gut. His digestion is off, his elastase or pancreatic enzymes are very low, so he could use some support with digestion as well. And then I did other testing on him as well. I did an organic acid test. He had some high candida and general fungal markers on that test, and some indicators that he was low on glutathione and had some toxic exposure. So I did a mycotoxin test, and he was positive for ochratoxin A and gliotoxin, two different types of mycotoxins. Mycotoxins are toxins put out by fungal organisms. And we did some heavy metal testing, and he was also high in mercury. This patient ate a lot of sushi. So what do we do? First thing to note is that, I'm a naturopathic doctor. Treatment plans are individualized, and plans are going to change every 2.5 months. So this was not all done at one session. We're going to look at some photo progression. You'll see how he did. But these were done over the course of multiple treatments. And, plans change every 2.5 months. So for bacterial overgrowth, I don't use any pharmaceuticals. So I'm going to obviously go at things with beautiful herbs and supplements. I use antibacterial herbs, things like grapefruit seed extract and uva ursi. For those elevated markers of detoxification, I did that additional testing I talked about. For the fungal overgrowth, we've got great options, things like neem and caprylic acid, wonderful antifungals. For the mycotoxins, I did binders, fish oil, and glutathione. For mercury, he reduced the predatory fish consumption and took chlorella when eating fish. For the no Akkermansia muciniphila, there is an Akkermansia probiotic. Also gave additional spore-based probiotics, prebiotics. And for adult patients, I work on 35 grams of fiber a day. Antiprotozoal herbs, things like artemisia and walnut hull. And I do natural H. pylori protocols plus digestive enzymes, things like mastic gum, things like that for H. pylori. And then I did put him on a multivitamin just to make sure there wasn't a nutrient thing I was missing. So this was John at the first visit, and let's look at how he did over different treatments. So this is 2 months later. It might not look super exciting, but we are seeing a lot of hair regrowth coming in. We can see all the line here coming in. And then 3 months later, significant hair regrowth at this temporal region. 2 months after that, and then at 1 year and 5 months later, we can see that his hair is back in the temporal region. This is the ophiasis pattern on the left side. Again, we're seeing with each visit, we're starting to get hair regrowth coming back in. And at the year and 5 months mark, he's got his normal hairline back. This is his front. At first, it doesn't look that bad until we can start to see that this is actually his hairline. He's got a widow's peak, and all of this is missing. The 5 month mark, the 7 month mark, and a year and 5 months, he's got his hairline back. All right, and let's jump into the second case with alopecia areata. This is a pediatric patient. We'll call her Sarah, not her real name. But Sarah's a 4-year-old female who came to see me. She started with this hair loss 6 months ago. This is the only patch that she's got, so she's patchy alopecia. So her history, her tooth was chipped 1.5 years ago, and then it's been a problem for a year, this tooth. And then they removed the tooth 7 months ago, and then the hair loss began. A few weeks later, the hair loss began, but that's because she was given amoxicillin because the tooth was infected. So we're seeing mucocutaneous site infection and antibiotics. The dermatologist wants her to do topical steroids. The parents want to avoid pharmaceuticals, so they have brought her to me. She has a history of thalassemia minor and a history of anemia, but we did an iron panel. Her labs are normal. She is not having any sort of deficiency in iron. So next steps, GI map stool test, and then some additional testing. So her H. pylori is high. She's at 1,400. So we got to clean up this H. pylori. Her normal bacteria, now she has a different profile. This is why I still have to go in and test each patient. I don't know what I'm going to see until I actually run the GI map on them. We see the opposite. She's got overgrowth of commensal organisms, actually high Akkermansia and high Firmicutes. So there's too much of this kind of normal or commensal. There's a lot of bacterial overgrowth on the rest of her stool test. So she's got the Enterococcus faecium, Staph, Strep, Methanobacter, Klebsiella, some Citrobacter frundi. She's got a lot of bacterial overgrowth going on. And she's also got high Candida yeast. I also did some additional testing on her. She had some Candida and high general fungal markers on an organic acid test. She was low in vitamin B2 and low in glutathione. We did mycotoxin testing on her. She was also high in 2 mycotoxins, ochratoxin A and citrinin. So for her treatment, we treated the H. pylori with things like meadowsweet, black cumin seed, and mastic gum. I used antibacterial herbs on her like berberine, garlic, and oregano. For her antifungals, things like neem, rosemary, grapefruit seed extract. Treated her mycotoxins with glutathione and binders. I recommended mold inspection or moving, but her parents declined that. We didn't really use topicals. Most kids and even adults with alopecia areata don't like to put things on their scalp. It's not about the scalp. You don't need to put any topicals on alopecia areata to fix it. You need to go treat the gut and the internal drivers of inflammation. And I did put her on just a kind of general multivitamin. So her progression, this was Sarah at the first visit. A month later, we're starting to see some little hairs coming in. At the 3-month mark, there's some nice kind of coverage of that area. 5 months, 7 months, 9 months, and then 13 months. So we can see that that whole area grew back in for her. So here's my contact information. I'm going to be answering questions in a minute, but if you somehow didn't get your question answered or you didn't think of a question till later, you can go to my website, either Root Cause Dermatology or Integrative Dermatology Center, and you can send me an email from either place. If you love dermatology like I do, or you're looking for a new specialty and you want to be able to treat patients, the root cause of patients to make them better, I have a root cause functional dermatology course. The next cohort is starting, that should be March 2nd. So that's coming up real soon. Yes, okay, March 2025, it's March 2nd. It's a comprehensive functional medicine training course. So I'm going to teach you how to analyze the GI map, how to analyze organic acid tests, mycotoxin tests, hormone tests, all of that. And we're going to get into then how to treat the gut dysbiosis that you see, things like H. pylori, SIBO, Candida, and the 7 most common derm diseases that you'll see in practice. So we go through acne, eczema, sebderm, psoriasis, rosacea, hair loss. And hair loss is both androgenic alopecia, so hormonal hair loss, and the alopecia areata, and keratosis pilaris. And instead of just seeing kind of general, these are the herbs and things I did, when you're in the course, you're going to see the exact treatment plans that I give patients for each visit. So for these two patients, you're going to see this is the exact treatment plan, the oral and topicals, the doses, the brands, absolutely everything. I pull back the curtain on everything and you see it all. There's 35 cases, 5 for each disease. And so you're going to see, you know, hundreds of treatment plans and GI maps for all of them, with a lot of retesting as well to see how their gut has done after treatment. So this course is for you if you have a passion for dermatology, if you're looking for a cash-based specialty. This is a really underserved market. If you're thinking, well, I haven't seen a lot of functional medicine or naturopathic, you know, talks or education on dermatology, it's because there is none aside from this course. There's so many people looking for this type of medicine and so few people doing it. So if you're looking to grow your practice, this is a great way. These patients are eager, they want to pay cash, they want to get better. It's really fun to treat patients that get better, right? You don't have burnout that way. And I just think derm is really fun because you can see the results and patients are so grateful and wonderful, and they will go out and tell their friends and family and fill your practice. So there's 2 options for licensed healthcare professionals. There's the cohort starting March 2nd. This one is recorded content released each week. And then every other week we get together in a live Zoom session. There's a lot of clinical pearls, case studies, just a lot of really rich information in the live sessions. And then at the end, you have the ability to be listed in the Find a Practitioner database. And past graduates of the course are getting a ton of referrals, and many have reported to me that the course has already paid for itself, just in terms of the amount of referrals that they've gotten. If you're not licensed, but you can still order labs, then you can qualify for the self-paced course. There's no live session, no contact with me, no ability to be listed in the Find a Practitioner database for the self-paced course. But if you're interested, you can go to rootcausedermatology.com. You can click on the top, the courses link, and then if you click on either one, you fill out the information, you'll be able to download a PDF and get more information on the course. So feel free to do that. And then there's also information in there how you can schedule a 10-minute call with me, and I'd be happy to answer any questions you have about either of the courses. So that is it for me, and I will turn it over and see if anybody's got any questions for me.
We do have some questions. The first one is, do you recommend GI map and your protocols for telogen effluvium?
Yeah, I mean, I recommend a GI map for everything, honestly. It's not an exaggeration. It's a requirement. Patients have to run a GI map before I see them for the first visit, because without knowing what's going on in the gut, we can't know what's going on in the immune system. So it's helpful for everything. I mean, and I treat all my other derm patients this way. So acne, eczema, psoriasis, they're all doing GI maps, and there's different patterns for different diseases. So for example, the eczema gut, there's certain things I expect to see on the GI map. It's very different than what I expect to see on the GI map for my acne patients.
Have the specific microbial strains and their metabolites that result from the microbiome, I guess associated with alopecia, been identified?
Oh, okay. Well, I haven't seen any specifics. Usually, even for the other derm diseases, like I know what I expect to see now again in the GI map, but I don't see a lot of research, or if there is, it's kind of willy-nilly. We don't know specifically what organisms, but I don't think we need to know specifically what bacteria. As you can see, like if they're an endotoxin or an LPS producer and you've got leaky gut, they're all going to drive that inflammation. So I see, and you can see from these 2 examples, one was insufficiency dysbiosis on commensals, one was overgrown. I don't see one exact pattern. I've really got to go in and treat it. But when you treat what you see on the GI map, you are healing the gut and lowering inflammation, and that is what is allowing the root cause level for hair to regrow. There's no symptom suppression in this whatsoever.
Do you recommend GI-MAP testing to ensure the gut has healed after treatment?
I do a lot of post-treatment testing as well. Sometimes I'll leave it up to the patient, so it's not 100% of the time. If they're clear and we ramp down and things have been going well, we may or may not redo one, but I like to be able to redo one, and a lot of patients want to redo it so that we can see exactly, you know, what's been fixed. And so you see a lot of that before and after in the course, in the case studies.
How do you know how long to keep patients on some of the herbs and protocols that you use?
So that's the method that I've developed that I teach in the course. It's years and years and hundreds of plans and patients, and that's the methodology that I teach.
Last question. Do you always treat H. pylori?
Yes, I'm one of those people in the camp. I don't like H. pylori. I know there's a debate within the functional medicine world whether it's, actually beneficial or not, and maybe there are certain things that it's doing or instances, but for me, I see it causing hypochlorhydria a lot. And like in the first patient where you saw protozoa, I almost only see protozoal growth in patients with H. pylori because it tends to be lowering the stomach acid and, causing that hypochlorhydria. We know it can lead to stomach cancer. So other countries like Japan takes H. pylori much more serious than we do in this country. But I treat it every time I see it. And a lot of times patients are like, well, I'll go get an H. pylori breast test, or I'll get a, test, H. pylori stool test, with my other provider. But what I have noticed is that testing is really not sensitive enough. The GI map picks up H. pylori that others miss. And it's not just that it's picking up stuff that doesn't exist, because it's there, and then I treat it with the H. pylori protocols, and then it's gone. So I know that it was there and that we've successfully treated it. That's just one of the reasons why I really love and require the GI map. And it comes standard with the GI map, which is pretty unusual. A lot of stool tests, it's an add-on. It's not an add-on for the GI map, it's standard.
That's all the questions we have for today. We'd like to thank you, Dr. Greenberg, for another great presentation on our channel. Thank everybody in the audience for attending today, and we hope everyone has an absolutely great afternoon. Thank you so much.
Thank you.